This lecture will be a bit different from others in this series. One part of preparedness is seeking training about practical skills that you can use to help others or to help yourself. In this session, we'll demonstrate some of those skills. For those who are listening on audio, I'll do my best to describe what we're doing and the principles that underlie it. We'll begin by discussing CPR, or cardiopulmonary resuscitation, and the use of automated external defibrillators, or AEDs. Then we'll discuss life-saving first aid. There is, of course, much more to first aid, but given our limited time, we'll focus on the most life-threatening injuries. Then we'll transition to a discussion of utilities and fire extinguishers.
Meow, Huples cat. Welcome to Where Everything Fails, How to Survive Any Disaster. And this is going to be a little different. This one is actually essential life-saving skills. And for this one, I'm actually going to show most of the video with a fewer interjections than I normally would. I absolutely agree with the guy that does this course that you absolutely need to get actual physical hands-on training, and watching videos or even reading books helps, but is nowhere near good enough for an emergency situation to respond using equipment and also using skills. So that being said, this is probably going to be long, so settle back, grab a coffee, vegan snack and enjoy. And also feel free to come back to this video on and off and actually think about the skills he's talking about, do some background reading, some background searching about those specific skills, and be honest with yourself. Do you have sufficient training to actually perform this stuff for real?
At the outset, I want to make very clear that this discussion is not intended to, and in fact will not, provide you with a formal certification.
However, a few girls and guys and other people out there who actually want a certificate, here's a certificate, and it's from the University of Huples Cat. Stop the video and do a page grab and you can have your very own certificate in emergency preparedness.
I would describe our session as awareness level information to talk about these skills, but I'll also recommend some places where you can seek more formal instruction and credentials when applicable. Let's start with CPR, which is cardiopulmonary resuscitation. This is a technique for providing assistance to persons who are in cardiac arrest, not breathing, and with no heartbeat. There are multiple historical origins for CPR that we might identify, but CPR as we know it now was largely based on the work of two teams of scientists. One team consisted of Peter Safar and James Elam, who had put forward the idea of rescue breathing, the pulmonary component of CPR. On the other team were William Cohenhoven, Guy Knickerbocker, and Jim Jude, who put forward the idea of chest compressions, the cardio part of CPR. Actually, in hospitals, before chest compressions became popular, for patients whose hearts had stopped, opening the chest cavity and manually massaging the heart was a treatment that was utilized.
This actually went on into the 1960s and early 1970s. It's fairly recent in human history. I think a golden rule for me is in grid down in an emergency situation that's ongoing and national or international, no vital signs means they're dead. So any efforts trying to bring them back to life is probably misdirected both in time and equipment. I would further add that CPR is pointless in a major situation.
While hardly gentle or free from risk of injury, chest compressions are much less invasive. It was the early 1960s when the ideas of rescue breathing and chest compressions were merged into the form of CPR that is most frequently taught today, in which both are utilized. 30 chest compressions, followed by 2 rescue breaths, followed by 30 more chest compressions, followed by 2 more rescue breaths, and so on.
You maybe thought compressions without breath. That is in fact now hospital standard. However, for most people, very young children who've been cold is a different scenario entirely. But for most people without oxygen in the bloodstream going through the brain, they will die and become anoxic, they call it, within about 1 to 2 minutes. The idea is that the oxygenation of the bloodstream is actually fairly high to start with, and by interrupting compressions and not flowing the blood through the brain, you're actually causing more harm than stopping to give the air. I think it's very situational. If you're out in the wilderness and you have a person on the ground who has vital signs absent, has no heart rate, and there's more than one of you, absolutely do rescue breathing. Somebody does rescue breathing, somebody does compressions, and you switch off. If you're on your own and you really like the person and you don't want them to be dead, you can try this. You'll get tired if you're doing it properly very quickly. So again, if you're in the wilderness, don't be surprised if you have to stop because of exhaustion. it's very unlikely to restart the heart without electrical shock by compressions. If you are going to do that, you do it in the first minute. Now you may have heard of the sternal thump. Flat hand like this over the lower third of the sternum and like that. It's not evidence-based anymore, but I've seen it work. I don't know, I'd give it a try in the wilderness.
Now, depending on how and where you're trained, you might see some slight variations in how CPR is actually presented. The most notable distinction is between layperson CPR and CPR for healthcare providers. Layperson CPR teaches protocols for individuals rather than teams, without the distraction of trying to locate a pulse, which is often difficult for non-medical professionals, and without the use of specialized medical equipment other than perhaps a basic protective face shield. There are many organizations that can provide certification in CPR, including the American Red Cross, the American Heart Association, the Emergency Care and Safety Institute, the American Safety and Health Institute, the National Safety Council, and many others.
If you have a baby or a small child and you haven't been CPR trained in small children and infants, you're a bad parent. Why haven't you? Goodness gracious me. There's lots of courses for most places available, usually for free or no money. Get it! If your child chokes and goes unconscious and the heart stops, that's not the time to try and watch this video to figure out what to do. Actually now, cat and dog CPR is also now a thing, and it's actually a good idea. I haven't actually tried it on Wolfie, but I might in certain circumstances use it. One of the things to be aware of when you're doing rescue breathing of any type at all is they often will vomit into their mouth and often into your mouth whilst you're doing rescue breathing. You can get the little one-way valves and all that sort of thing. But again, it depends on the circumstances, it depends what's going on around you, and it depends on who the person is, about the level of risk you're prepared to take to try to do CPR. Remember, it's not a stressful situation, CPR. You only do CPR when they're dead. There's no pulse, there's no breathing. That means they're dead. So all you're doing is trying to get them back to life or trying to keep them going until somebody comes along that can get them back to life. They've died. There's no stress here. The only outcome here is death. If you do CPR and they survive, that's a major bonus. So don't get freaked out, don't get stressed, don't start screaming. What you have here is a dead person. Think of it in those terms. Whatever you do might help. Whatever you don't do won't make any difference.
As a note, we're going to focus on adult CPR. For infants and young children, there are different protocols. And we're actually going to bypass rescue breathing and focus on what's called hands-only CPR, meaning that chest compressions are all that will be done. This has been found to be as effective as traditional CPR, and members of the public seem more willing to do it since it involves less physical contact. There are still some instances where CPR with rescue breathing is recommended, such as for children, drowning victims, persons known to have respiratory problems, and with drug overdose.
One of the many reasons I actually recommend wilderness survival first aid courses is that if there's any sort of spinal injury here, you've got to move them very, very gently. You've got to move the head and neck very, very carefully and preferably in line with the spine. And if you turn the person, you need 2 to 3 to 4 people to do it so the spine stays straight. You don't want to have a broken spine that you move the person and then it cuts the spinal cord. That causes permanent paralysis or quadriplegia or death.
If a person appears unresponsive, first check to be sure the surroundings are safe. If they are, approach the person, tap their shoulder, and see if they respond. If not, open the person's airway by putting 2 fingers under the chin, 2 on the forehead, and tilting the head back, and then check for breathing.
They have no pulse, they have no breathing, they have no response at all. They are dead. The pupils don't respond either. That's something you might want to think about if you've got sufficient skills. So what's the outcome here? About 1 in 5, 20%, will actually come back from the dead with CPR in the community and in hospitals. If you have to do CPR for about 10 to 11 minutes without the heart starting, it can start and stop again, okay? So you have to keep checking them. If they have no heartbeat for 10 to 11 minutes, the chances of clinically them coming back to life is pretty much 0. This does not mean that if you start CPR you just stop at 10 minutes or at 20 minutes. We do in hospitals, but the idea here is that if you're in the community you have to keep going until you physically can't anymore once you start CPR. That's one of the main reasons registered nurses and doctors and paramedics often will not restart CPR in the community into somebody who's obviously dead, because you don't really want to be there for 2 hours trying to restart somebody who's dead with their family and friends screaming, and you know there's no point because they're never going to come back. Now that brings us to the most essential thing, which is only generally speaking available in community centres and hospitals and shopping malls, though it's becoming more standard. That's the AED. An AED is an automatic external defibrillator. All a defibrillator does is give you an electric shock. We've all seen Frankenstein, he's alive, when the lightning strikes. It's the same thing. The heartbeat is either completely out of control, so you can't feel a pulse at all, or isn't beating at all. The idea is that a quick shock, usually about 200 to 300 joules, into the heart, around the area, will actually restart normal rhythm. This is entirely possible. AEDs look complicated, they're not. They're very actually simple, straightforward to use. In real life, about 12% of people that suffer vital signs absence in the community will actually have a heartbeat again. That doesn't mean they'll ever leave the hospital. Some do, but most will not. So the chances are here the person will stay dead. So again, use that to inform your decision making. This is not ER, this is not TV. Nobody's running around screaming and panicking to try and stop them from dying. They've already died. Calm down.
I like to recommend checking for breathing by kneeling next to the person, putting your ear to their mouth and looking forward toward their chest. From here, you can listen for breathing, you can feel if the person is breathing against your face, and you can watch for breathing to see if the chest rises. Shallow or intermittent gasps, or what's called agonal breathing, is not really breathing. If there is no breathing, direct someone to call 911 or call 911 yourself, preferably on speakerphone.
This of course assumes 911 is the emergency number. In large parts of the United Kingdom it's 999. In fact, I believe in certain rural areas of Canada and America, I'm not sure about America, it isn't a number at all, it's a telephone number. So if you're travelling, make sure you know what the local emergency number is. Don't just assume it's 911 or 999. This is a major error here in my opinion. If you are on your own, you do everything you can do. If you're on your own, you might want to alert emergency services before you start CPR. You might want to do CPR for a couple of minutes or 5 minutes and then go quickly, alert emergency services and come back and resume CPR if you're on your own. If there's one or more people there, when you tell them to go and get help, to call 911 or to get help, but be specific, if you tell them to call 911, it's a lot easier, they'll do that. Tell them to come back and say, go call 911 and come back to me, right? You want them to come back. Don't assume they will. They might phone 911 and go, oh, this is awful, I'm going home. And then you're stuck there on your own and maybe they didn't give enough information to 911.
CPR is ideally performed on a hard, flat surface. Kneel on your knees, centered over the person's chest. Locate the center of the person's chest, this is where a bone called the sternum is located, and place the heel of one hand there. Grasp that hand with your other hand, fingers interlocked, elbows locked, and push hard and fast, generally to a depth of 2 inches or so. You want to keep up a pace of about 100 beats per minute, which is about the same as the Bee Gees song, Stayin' Alive. So if you know it, think of that for your beat. Now, a couple of things to know about CPR. First, this takes a lot of energy, but the goal is to keep going until help arrives or until the person becomes responsive. Gravity can help you. Push from the shoulders and take a stance such that you would fall forward if not for resting your hand on the center of the person's chest. Second, this is not a gentle process. Ribs may break. You may hear it or feel it. Be prepared for that, but keep going. Do make sure that your fingers are elevated, which may prevent some ribcage injuries, so it's the heel of your hand that's doing the compressions.
I'd recommend most lay people do 60 to 80 beats. The standard now is about 100 or so. The critical thing here is not the pressing down. The pressing down has to be in most adults 1.5 inches or so. It's a lot, which is why the ribs often break. The critical thing is when you let go. It has to expand fully. If you just go boom, 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 and the chest never re-expands, the problem with this is that the heart has stopped. It may or may not be because of heart muscle issues, like a heart attack, but the only time the heart muscle has blood flow through it is during diastole, during relaxation. So if you just keep pressing systole, you're pushing blood to the periphery in the brain, that's good. But if you don't allow the chest to re-expand fully, you are cutting off blood supply to the actual heart muscle. So it's a bit of a technique. I've done it on people, many people with arterial lines, and so I can actually see the waveform and the systolic and diastolic and mean pressures. It's an art form. Do the best job you can. But just going at it really fast but shallowly is worse than useless. You have to do it so it's deep enough and steady enough that it fully comes back up. That is utterly critical, and you have to keep going for a long time. So again, when you see on TV shows and hospitals these days where they're going like this, it's rubbish. They don't know what they're doing. The other big miss here is if there's no spinal injury suspected and it's safe to do so, before you start CPR, actually elevate the legs, and if you can, put a pillow under the buttocks and elevate the legs above that. What that actually does is it means the compressions when you press the blood, the heart squished by the chest by being pushed down. The blood actually will go to the brain and the lungs and the heart a lot easier if it's not having to go through the legs and back again. Obviously over time you get ischemic legs and you would die, but at that point you're not going to get recovery anyway from CPR.
The same organizations that teach CPR generally also teach the use of automated external defibrillators, or AEDs. Many public buildings now have AEDs positioned in common areas. If doing CPR in a public building, in addition to having someone call 911, direct someone to locate and bring an AED. The sooner it can be utilized, the better. The heart is regulated by electrical impulses, and a condition called ventricular fibrillation, in which the electrical patterns are disrupted so the heart can't function normally, is life-threatening. The use of electricity to restore normal heart function is called defibrillation. The first successful defibrillation of a human heart in the United States was reported in 1947 by physician Claude Beck. While many scientists worked on issues related to defibrillation, Bernard Lowen and Baro Berkovitz research in the 1960s led to the widespread use of defibrillation in medical settings. However, it's really been the past 20 years or so when we've seen AEDs, which are designed for public use, located in public areas of buildings.
Many hospitals actually have gone to using AEDs, the same as you find in community centres. Some have a few more bells and whistles, but they're basically the same. They're actually idiot-proof and very easy to use. So don't be frightened of asking somebody to go and get an AED. If you're in a shopping mall or near a community centre and there's more than one bystander, you go and call 911 now, say I have an unresponsive patient on the floor, and come back to me. You go into the community centre, go into the mall, find security as fast as you can, get an AED and bring it back to me.
Unlike traditional defibrillators, no medical expertise is assumed for using an AED. Again, the first goal is to make sure that the scene is safe and that 911 has been notified, and the area needs to be dry. The person should be on a hard, flat surface, and unlike for traditional CPR, the chest needs to be exposed. Each AED model is a bit different, but follow what's written or illustrated on instruction sheets. This will involve placing adhesive pads, they're included with the AED, on the patient's chest. The machine will probably talk to you with a message telling you to stand clear while the heart rhythm is being analyzed.
When these things talk to you, it can be quite startling.
Stay calm. Follow these voice instructions. Make sure 911 is called now.
Stay clear of patient. Do not touch the patient.
Clear?
Then, the machine may tell you that a shock needs to be administered.
Deliver shock now. Shock delivered.
That might occur automatically, or you might be asked to push a button to do so, and then the machine may tell you to continue CPR. Simply follow the prompts that the AED gives. There are other cases in which a person is not in cardiac arrest, but still requires assistance. This is the realm of first aid. And once again, what I'm providing in this session is neither training nor certification, but just a broad overview of principles. The same providers who offer CPR and AED training also offer first aid training. Learning first aid can require pretty extensive study, so we'll just talk about a few points here. In 1974, a physician named Henry Heimlich developed the Heimlich maneuver, which is an emergency intervention for persons who are choking. There's a universal sign accepted to indicate choking. It's crossing the hands over the neck. You can also ask, "Are you choking?" to a person who appears to be in distress. If someone is able to cough strongly, then encourage them to do so, but be vigilant in case their status changes. If a person is having difficulty breathing, coughing, or speaking, or if their airway is fully blocked, the Heimlich maneuver may clear the blockage. Ask someone to call 911 and put it on speakerphone if possible. To begin, stand behind the person with them leaning ever so slightly forward, because if they become unconscious, you don't want them to fall backwards onto you, pushing you both down. Make a fist and place it against the person's abdomen just above the navel, with the thumb side of your fist inward. Grasp your fist with your other hand and give abdominal thrusts. You're going in and up to dislodge the object. Repeat until the object is dislodged. If the individual becomes unresponsive, then begin CPR.
He misses a critical thing here. A large number of these choking cases occur in private in children's bedrooms or cribs. There's not much you can do. You find them dead and you try and bring them back and you probably won't. Be careful what you give your kids to play with and careful what they have access to. But for adults, a lot of adults get embarrassed and they will go to the washroom or go outside. If they're going to the washroom and they're going outside, follow them. Do not assume that they are okay to go outside and they'll clear it and be fine. You might find them in the washroom dead, and actually doing CPR in a washroom is quite technically difficult.
Sometimes you may encounter a person who is breathing, but who is unresponsive.
In 30 years of nursing, I have actually seen CPR called on people who were deeply asleep and deaf. They didn't respond, they were deeply asleep, they certainly didn't respond to verbal. Sufficient pain was not given to wake them up. So that's something you might want to think about. Press above the eye, here, squeeze the trapezius. If they don't respond to that, they're not responsive.
A standard practice is to make sure these persons are in the recovery or rescue position, which helps to make sure they will maintain their breathing. Again, have someone call 911, or if no one is present, do it yourself, because an unresponsive person needs immediate care.
If you can, make sure there's no spinal cord injury. If it's suspected at all, you can use different methods of opening the airway, and they are taught routinely in basic CPR courses, so go and get trained.
Now, it's important to acknowledge that there is some debate in the field about whether the recovery position is beneficial for all patients. One particularly important thing is to continue to monitor the person. One critique that has been made against the recovery position is that it leads to the presumption that the person is breathing just because they were when they were put into the position. Health status can change quickly and it must be monitored carefully. Again, there are some variations in how the recovery position is taught, but here's the general idea. As before, this is for adults, as infants and small children may need to be handled differently. To begin, it's best if the unresponsive person is lying on his or her back. Make sure the airway is open by lifting the chin and tilting the head. Place the person's arm that is closest to you at a 90-degree angle. Then bend the arm that is farthest from you so the back of the person's hand is against the cheek. Next, bend the person's knee that is farthest from you so it is pointing up at a 90-degree angle, and then carefully roll the person toward you onto his or her side. You can use the upturned knee to help roll the person. As you do so, be careful to protect his or her head. When the person is turned, the top leg should remain bent and the person's head should be resting on his or her arm. The purpose of this position is to keep an open airway while the person is unresponsive.
This actual method is really great for moving people in bed who are immobile or difficult to move because of broken legs or age. What I would say is be very, very careful with this because they can easily roll out of bed, and I've seen it happen in hospitals. That's why your side rail is supposed to be up if you're doing this as a one-person technique, and it's best to do it with a two-person technique with the other person on the other side.
There are many things we could identify that qualify as first aid. The idea of teaching first aid, that is, having non-medical professionals rendering medical assistance, goes back centuries, if not longer. However, historians often identify the starting point for what we now know as modern first aid in 1878, with the work of Peter Shepherd. Shepherd was a military doctor who was also involved in the Order of St. John in England, which developed an ambulance service staffed by civilian volunteers. The first public class in first aid was offered in London in 1878. In the United States, the American Red Cross helped to popularize first aid training and services, especially in the early 20th century. Again, because there is so much ground to cover, I'm just going to note some high points. First, learn to recognize the signs of life-threatening conditions. All of these require immediate treatment. Call 911 and seek assistance.
Before he gets into his, I'll offer this off my own bat. Everybody in the family, including small children, should know the basics of CPR, know how to summon help, know what to do if somebody's unresponsive. What I would say is a minimum for you people to know and understand and be confident to diagnose and treat and get help for are the following. This is my list, not his. It'll be interesting to see how they actually line up. I'm fairly sure they will. It's pretty standard stuff. Stroke, heart attack, shock, hypothermia, hyperthermia. If you've got the time and the interest, actually stop the video right now and Google those 5 things and look at basic signs and symptoms of them for the layperson to understand that they're looking at shock or they're looking at heart attack or they're looking at stroke. Again, I would do definitely a minimum a basic CPR course, and I would really encourage you, if you can, to do a wilderness survival course or wilderness first aid course. They're really going to help you in the nitty-gritty, in reality, deal with these things. I've in the past mentioned stop the bleed. I absolutely fundamentally think that's a very critical skill that all members of your family should have access to, except for very young children. I think people should know what to do. If you have an 8-year-old or a 9-year-old kid and you lose your arm in a chainsaw accident, go unconscious, I hope that child has access to a tourniquet and knows how to put it on and knows how to summon help. Don't just assume that scaring children is a bad thing. Children are fine if things are given to them in proper ways, and this is what we do, this could happen, I'm going to do my best not to, but this is what we do if this happens. Kids can go, okay, and they'll just file it away. And if they can use it, they might save your life.
Shock is a condition that exists when there is not enough blood flow to deliver the oxygen that bodily systems require. Injuries, infections, allergic reactions, dehydration, and a number of other factors can cause shock. One of the impacts of shock is a significant drop in blood pressure, which can lead to death. It may be difficult to fully determine whether a person is in shock. So again, err on the side of caution and seek medical treatment if you think it's occurring. Persons in shock may appear confused, or while conscious, may not be fully alert. To judge a person's health status, the medical community will sometimes use the standard conscious, alert, and oriented times 3. As it suggests, this means the person is in fact conscious, is responsive to the environment, and can answer 3 orientation questions by indicating their name, their current location, and the date or time. Persons who are not conscious, alert, and oriented times 3 may be in shock or may have other conditions that require care. In addition, persons in shock may be pale and have cool extremities, that is, their hands and feet, and they may be breathing quickly with a fast but not necessarily strong pulse. Let's talk about finding the pulse. As I mentioned earlier, a lot of people have trouble with this. What you want to do is place a person's hand palm up, place 2 fingers, the index finger and middle finger, just below the thumb on the thumb side, and you'll feel what's called the radial pulse.
This is only going to work if the systolic blood pressure is over 90 millimars of mercury. It's not going to work if the pressure is lower than that. And oftentimes with illness like hypovolemia or shock or even heart attack or stroke, the blood pressure will be lower. In fact, for women, oftentimes elderly women will have normal high blood pressures of 75 to 80, and it's really hard to find pulses on them. Now, there's a fair number of people that have their radial pulse on the opposite side. Their ulnar and radial actually are transverse. So bear that in mind. Don't just go like this, oh, they're dead. Make sure they're dead. Use pain, feel there. And for that reason, I don't actually recommend using the radial to find the pulse. I think it's quite dangerous to do that. Shock will absolutely drop flow to the arm. I'm not really convinced people should be assessing pulse using radial pulse.
There are multiple other locations where you can find a pulse, but the radial pulse tends to be convenient. Now, this may take some practice to make sure that you actually can pick it up and that you're not inadvertently feeling your own pulse reflected back.
This is very common, and for this reason I recommend that you use the carotid pulse or the femoral pulse. Now, that being said, never assess the pulse on both sides of the neck and both sides of the femur. You actually need to figure this out on yourself and your partner and your animals before it's a crisis, so you can actually fairly confidently figure out where the carotid is. In fact, in a lot of men you can see it beating. You have to palpate it. Remember, the pressure when the heart moves might be so low that you can't see it. So you need to feel it. So good, knowing where it is, pressing in gently, feeling it, good. The reasons people don't recommend the carotid is that you might actually cause a stroke. It's rare, but it can happen. But the thing with it is that if they seem to have had a heart attack or they're in deep doo-doo, you need to take a few risks, and that's one of them. Don't press in too deep, don't press in too long, like I'm talking about 1 to 2 seconds, and don't never press both sides.
I can't tell you what a normal heart rate is because it really depends on the person and their condition, including whether they've been doing any exercise recently. But 60 to 100 beats per minute is usually the ballpark of normal.
If the person's young and healthy or old and fit, you can actually get a resting heart rate of 30s to 40s. It's not that uncommon. Kitty, when they actually anaesthetize her, her heart rate drops to mid-40s. So she has to warn them before she has anaesthetic procedures that that'll happen. It's normal for her. The key thing when you're checking pulse, usually by femoral, is actually to figure out, is it regular? Or is it skipping, or is it completely irregular, as well as whether it is in fact beating. So that sort of information is important to transport to 911 before they arrive as well.
Persons in shock may also feel sick, be nauseous, be sweating, and in some cases they may be unconscious. Keep the person warm in a reclining position and get help.
Never ever use direct heat on the skin from anything including hot packs that you might find in your first aid kits. You get wet stuff off them, even if it means stripping them naked, you get them out of the wind and you cover them with dry blankets, preferably wool if you have them, or emergency blanket and then wool, whatever you need to use. You can also strip off yourself and get very close to them. Again, I'd consider the situation where you're doing this and who you're doing it with, but it's actually a very effective way of warming people up.
As I mentioned, there are a number of possible causes of shock, one of which is an allergic reaction called anaphylaxis. Food allergies, bee or other insect stings or bites, certain medications, and other triggers can cause this. One key concern here is that anaphylaxis can cause respiratory distress or stop breathing entirely if it's untreated. Some persons carry injectable epinephrine, which is an emergency treatment for anaphylaxis. It does not replace the need to seek medical attention, but it can provide some immediate relief. Persons who carry epinephrine have been trained to use it. In the event that you need to assist, while recognizing that there are some differences in injection systems, they generally work by opening the container, placing the side where the needle will come out against a thigh, it will go through most clothing, and pressing a button, and then holding the device in place for a sufficient time for the medication to be injected.
If you're in this scenario and the syringe is expired and there's no other syringes, use the expired syringe. Never use it anywhere except in the upper thigh, ever. Don't be trying to use it in the arm. Now if you have no legs, you'll have to use the arm, right? Situational. What you will never ever see anybody ever do is cardiac. Never ever do into the chest with an epinephrine syringe. Ever.
Another emergency condition is a stroke. A stroke occurs when the brain does not receive enough oxygen because of insufficient blood flow. A blood vessel may be blocked in what is called an ischemic stroke, or a blood vessel in the brain may break or rupture, leading to bleeding that deprives oxygen to other areas of the brain in what's called a hemorrhagic stroke. Either is an emergency. Signs of stroke include problems with vision, speech, or balance, severe headache, nausea, a feeling that one side of the body is weak or numb, and disorientation, not being conscious, alert, and oriented ×3. There is a test for stroke known as FAST. The F stands for face. If you ask the person to smile, look for whether one side of the face droops. The A stands for arms. If you ask the person to raise both arms, are they able to do so, or is one arm less responsive? The S stands for speech. If you ask the person to repeat a sentence, can he or she do so, or is there confusion or slurring? Finally, the T stands for time, which means help is needed as soon as possible. In stroke care, medical professionals refer to the golden hour, meaning the short period of time, usually within an hour, after a stroke when medications can be given to control or even possibly reverse some effects. But professional medical care is required as quickly as it can be delivered.
I actually use be fast rather than just fast. Fast is a simpler thing to use, but I think we're all intelligent enough to figure out be fast and use that. If the symptoms resolve and they get better, they should go and seek medical advice straight away anyway. Now whether they do or not is up to them, right? Okay, people make their own decisions. Just because they have a bit of slurred speech and their eyesight's a bit off on one side and they're a bit wonky for about 4 or 5 minutes and then they're completely normal, doesn't mean that they're out of danger. They should go and get medical advice, preferably from an emergency centre. Now the old way of this was 60 minutes, then it became 4 hours, then 8 hours. It's now actually 24 hours. They think the new clot-busting drugs and angio procedures and stuff like that actually are beneficial for up to about 24 hours. In fact, a lot of the people doing it will actually do it beyond the 24-hour range now. It's kind of irrelevant. With a stroke, minutes equal brain cells. The longer it takes to remove the obstruction or fix the gap where they're bleeding from, everything beyond that is dying. And it's your actual self, your actual brain cells that are dying. So you actually want to get this done as fast as you can. What I'm trying to say here is you may think somebody had these signs and symptoms 8 hours ago, so there's no point taking them to a hospital. Actually there is, and it's also important to get them there fast, preferably by ambulance.
I would encourage everyone to complete Stop the Bleed training.
As would I. Opioids and the rest of this stuff, I'm not going to show. You can get the course and look at it. You need to get training, and videos aren't really sufficient.
Never hesitate to call 911 and seek emergency treatment. In fact, 911 dispatchers are often trained to guide you through first aid. And in many cases, first aid is just that, first, as an emergency intervention before medical professionals begin their treatments.
In SHCF, it's the first and only response, so get some training.
I'm going to turn now to practical skills for use in the home. One thing every homeowner should know is how to shut off utilities, including electricity, water, and natural gas. There are a number of reasons why you might want to do so. In some situations, electricity may become a fire hazard. If electrical wires are exposed, it's also an electrocution hazard. Most homes have a circuit box with a control for individual circuits and for power to the home as a whole. Ready.gov, the U.S. government's emergency preparedness site, recommends turning off the individual circuits and then the switch for the home as a whole.
This is to avoid overload.
If you live in an apartment, your utility controls will likely control only your residence. So be aware that utilities may be operating in other units and in common areas. And for electricity, remember that while you can turn off power to your home, power still may be flowing to your home through an overhead or underground power line that leads into your circuit box. If there's a natural gas leak in the home, it could lead to a fire or explosion. If you believe that there is a leak, leave a window open, evacuate the house. If you can shut off the flow of gas from the outside, do so, and then call the gas company. There are different types of shutoffs, so check with your local gas company on how to do so, and for general natural gas safety issues. There may be circumstances where a water supply has been compromised, such that it's not safe to use. Sometimes a boil water order will be issued, in which water must be boiled for sanitization before it can be used. Other times the water supply may be so severely impacted that it shouldn't be used at all. Your local emergency management officials will let you know if that's the case.
This depends. In an SHCF situation, be it local or large or ongoing or short duration, you decide for yourself and use the precautionary principle, i.e. shut it off until you know it's safe. There may not be any need to shut off the water mains and the gas for some emergency that you're aware of, but there may be a need in case that emergency gets out of hand.
If you need to shut off the water, which may also be due to broken pipes or even to repair water lines, make sure you know where the shutoff valve is located. Again, this will vary by location, so you should check with your water company. Finally, fire. Every home should have a fire extinguisher, and residents should know how to use it.
Yeah, but don't forget a smoke alarm on all levels of the house, a smoke alarm that works and has been regularly tested and has frequent battery changes. That's more important than anything else, I think. Anything else. He also actually then goes on to talk about multiple different types of fire extinguisher. Again, that's pretty basic and straightforward. What you actually basically need is a red one, and you need one that can work on most fires that you would encounter in your home or in your vehicle.
Only use a fire extinguisher if the fire is small and has not spread from its point of origin, is not providing high levels of smoke or fumes, is not obscuring visibility, is not preventing you from breathing, and is not overheating the room. Also, and this is very important, make sure you have an evacuation route behind you.
If there's any doubts at all, you just bug out, get out. Life over property every time. Hesitation because you're worried about losing property can end your life. Leave.
I hope you never need to use these skills, but knowing them and seeking additional training to practice them and to become certified is a critical part of preparedness. Until next time, be safe.
This was long, but I hope it was helpful. But you really do need to get realistic training and real training. If you can't get training because of your rural location or the country you're in, watch videos, read books, and try practicing yourself, on yourself if necessary, on pets. Next time, it's what to do in a fire. I'm not altogether sure how useful this is going to be. It's pretty straightforward, but after that we will have earthquakes. Not a bad course, quite enjoying it, and I hope you're enjoying it. As wherever, if you disagree with me, say so in the comments. If you disagree with what you've watched on the video segment from the course, say so in the comments. If you have additional information to add, please feel free. Remember, this channel allows links, so go for it. And also, have a great day. Toodles. This has been a 2021 Wolfie Terrier production, getting very excited about Christmas.